it's nice to be with you. And as Sarah said, I've been working at the Royal Fleet for a long time now. And when I was asked to prepare the talk, the title was "What's New in Palliative Care." Don't worry, since you've been doing other things, bugger all has changed. However, I thought I'd bash your ear about a few things today. I know you know all this stuff, and you've probably got lots of experience of handling such things as difficult conversations towards end of life and so on. You know what drugs to use for symptoms.
Phil, can I just stop? A lot of people can't. Some people can't see the slides for some reason.
Oh, can you do anything your end, Vanita? I've shared it. I don't quite know what else to do.
Yes, most people
can. I'm not sure. Sophie and Eugenie, can you maybe sign out and sign back in?
I'll wait for you. Don't worry. You're not missing much, really.
That's not true.
Oh, they've both left and they're going to come back in, I think.
Okay.
Everyone else can see it.
Yeah, everyone can. We can as well.
Hey, Vanita, is that your kitchen you're in?
Yes, it is.
Yeah. It looks like an old chemotherapy laboratory with all those pots and things. Is that? I think I can see some vancomycin over your left ear roll. No, that's just an antibiotic. Have you got anything else in there?
No, but Phil, this is being recorded. You know, I'm going to stop recording.
Fantastic. Where's it going to go? Who's going to hear it?
It's going to go on the health education website.
Oh, how utterly marvellous. I'll try not to swear again.
I'm just asking, Sophie, can you see the slides now? She's just rejoined. Yeah, she can see it.
Yeah, go for it, Phil.
There you go. Yeah, carry on.
Yeah. Was there somebody else as well, though, Vanita, or is that okay?
There was one other person, Eugenie.
Yeah.
I think we just probably... Yeah, she's just come back in. Or he might. I don't know.
You type very quickly.
Yeah, everyone can see.
Oh, fantastic. So this is my little list. Listen, I appreciate, as I said, that you've got great experience already, but it might be worth sharing some thoughts, hopefully, if I rattle through quick enough. I'm sure you've had some talks which have involved evidence, and that it is not very common in palliative care that we apply evidence to what we do. However, there is some evidence for talking to patients about what they want and what they don't want prior to them needing it or prior to losing capacity. So it is never a waste of time in the clinic room or in the acute setting to have a conversation. You may discover something very useful about how they feel. So give it a whack. In terms of when you have those conversations, of course, the best scenario is when the patient raises it. However, clearly there are many who never voice it willingly or rather voluntarily. And it may well be that the time to have the conversation is at the point of diagnosis, especially when disease is very advanced when it's found, relapse or progression through therapy, or when you come to the point of knowing that the toxicity of what we're doing is outweighing any benefit. And then in the context, perhaps treating patients with cancer is less likely for this, multiple hospital admissions, but certainly in other branches of medicine, it could be a very good trigger to have a conversation about what we're doing and maybe we should change the direction. How you do it, of course, hopefully is tailored to the patient. Not all of us have the same style, and that's good. Different styles suit different patients. However, try and perhaps explore a little bit about that patient's individual ways and preferences before launching into a conversation. I've stuffed up many a time going too far too soon. And I think the use of a phrase along the lines of, listen, if I say too much or go somewhere you don't want to go, just tell me to shut up, can be very useful. It gives the person that reassurance that they can actually stop it and duck out the conversation. In terms of scripts, well, of course, there isn't one, but sometimes lists like this can be useful for individual patients, particularly the bottom one. Sometimes, you know, if you've got someone who is stubbornly not going there, but loves their 18 cats, you know, that might be the way in to say, have you thought about what's going to happen to them? And it might open up a door. I'm not saying that any of these questions are ideal for everybody, but maybe talking about something other than the disease itself unlocks the door. So it might be useful for some. Just to say, formal documentation of patients' wishes can be very helpful. I know they're not necessarily very common, especially in the form of an ADRT, which is, I'm sure you appreciate, legally recognised as such in the Mental Capacity Act. ADRTs are useful, but when the patient's still able to talk to you and tell you what they want, they are irrelevant. It really is only, as you know, when they've lost capacity. So I just thought I'd emphasise that. I don't think it's the case that we need to tell every single patient to make one. Having a conversation in the clinic room or the general practice surgery or in A&E is as valid and powerful. So write it all down and communicate it. Just a quick word on DNACPR decisions. I get a bit vexed about this. You will remember the Tracey judgment from 6 years ago, which essentially says we're obliged to discuss the fact that we're going to make this decision. It doesn't say anywhere that we should ask a question. We're informing the person, or if they've lost capacity, their nearest and dearest, of the decision. And that's really key. You will have seen colleagues, and possibly done it yourself, ask the question, would you like to be resuscitated if your heart stops beating? Or would you like us to try and restart your mum's heart if it stops beating? Now, that is really difficult for the person, particularly if it's asking them about a loved one. Just don't ask. It is literally informing them gently that we've made the decision because it is the right decision. And I think we should stick to that and never rip one up once it's made. I'm not going to go into that because I know we've got a very short amount of time. Of course, that there are ways of phrasing that the team feels that there is no benefit to a resuscitation attempt. Again, we will get it wrong, but hopefully most of the time it will be not received well, but received with a certain amount of acceptance and understanding. And it's not a case of asking for consent, agreement, acceptance. It is literally informing them. And you can say, you can be angry, you can disagree, you can not accept it, but that is the decision of the team. And that's where it stops. I've made that sound so easy. In terms of the reason I get so vexed about it is because it's the only treatment that we're supposed to discuss when we're not going to do it. Every other treatment you discuss in order to get consent in order to treat the patient. It is completely cockeyed and stupid, but it's what it is. If it was NICE, I think CPR would be outlawed because it's absolutely not cost effective, except for people with very specific indications. And as you can see, even in hospital arrest survival is pretty poor, and that does not take into consideration all the patients who survive with significant neurological sequelae. Out of hospital arrest is much worse than 12%. I don't know where that study was, but it's more like 2.2, perhaps a tiny bit higher. Again, with a significant incidence of neurological damage. So in other words, I don't think we should resuscitate patients, but I'm a palliative medicine doctor. It's your decision, not the patient's, not the family's. Nobody can demand it, and it has to be ours. And we have to be brave and what's the word? Have the strength of will to stick to it. I'm going to go into easier territory now. I'm just going to run through a quick case, just to illustrate a few things, just to remind you what it's all about. So this is a story of someone who was 55, background of working as a community carer, and in fact she was the main carer for her older husband, who unfortunately had a left hemi after a stroke. And she had, when we first met her, pretty advanced metastatic colorectal cancer. Liver disease was predominant, and she was on a cocktail of paracetamol, codeine. Pain was beyond that now, and she also had persistent nausea. So, can you remember what your opioid dose equivalents are? Vanita, I don't know if you can see anyone, if they type in an answer, and you can tot up the votes. Can you do that?
Yeah, or we can get people to raise their hands. I know you can't see though.
Anybody, yeah. They could be lying, or you could be. I don't know. So stick your hand up if you think it's 5. Tramadol's 100 milligrams, equivalent to morphine 5, morphine 10, or 20, or 30 orally. What's the hover? Sarah, are you voting?
Yes, boss.
Or maybe if people can put it in the chat.
You can put it in the chat. Stick your hand up. Are they being brave, Vanita? Are they putting an answer in?
They are.
Hey.
So 10, it's all different, 10, 20, mostly 10s and 20s.
Well, that's good, because it's 20 in my book. So tramadol, although it's only a fifth as potent as morphine, because they make 50 and 100 milligram capsules, that's quite a big dose. So the smallest dose available is like 10 milligrams of morphine, a 50 milligram capsule. So be really careful if you switch someone to or start someone on tramadol. Have an awareness of that, because it can send people away to the fairies very easily. Don't ever take it for a headache. Okay, what about a fentanyl patch? 12 mics per hour. How much morphine in a day orally do you think that might equate to? 10, 20, 40, or 90? Have a punt. What's the scores on the doors, Vanita?
Quite a few 40s.
Oh, get in. You passed. Spot on. 40 milligrams is about right. There is a bit of a variability. So again, you may not necessarily want to start someone on a 12 mics patch who's opioid naive. Again, because you might cause some toxicity. Good. So go back to our lady. We popped her on some Severodol, so morphine tablets, immediate release, 10 milligrams every 4 hours, plus PRN. And Vanita, can you again let me know what the answer to this question is? What do you think her daughters were very concerned about when they heard that we were going to start her on some morphine?
So one person's written addiction.
Yep.
End of, addiction, that she was dying. End of life.
Yep, all of those are true. Or we're trying to kill her. That came up. Yeah, they were very, very anxious about what we were doing. It's useful to know codeine. I'm sure you do know. In most of us, part of the way codeine works is it's metabolized into morphine. 60 milligrams of codeine is about 6 milligrams of morphine equivalent. So sometimes it helps to reassure people, hey, listen, effectively you're on this already. We're just going to give you a little bit more. And that sometimes helps, not always, I have to say. So yes, we thought we were trying to kill her, that she would become addicted. Oh dear, I flicked onto the next slide. Addiction is extremely uncommon in cancer-related pain. And the biggest risk factor is that someone's had a previous addiction problem. If you look after someone who develops cancer and cancer-related pain with a background of, for instance, IV drug use and methadone maintenance, general advice is refer to the palliative care team for advice, but also if they need some opioid on top, give them some, and ignore the methadone and just use, depending on their background, either morphine or oxycodone, preferably orally if they can manage, and titrate to effect, but get some help to do that. Do not think that because they're on methadone, they've got that past history, that we shouldn't give them anything or fiddle around with the methadone. It's a very unwieldy drug, not for the uninitiated. So get some help quickly, but be nice to them. You might be the first person that's ever been nice to them in their lives, I think is the case. Rose herself was very worried about constipation, which is, of course, almost a guarantee with regular opioid use. There's no specific guidance evidence for one laxative or combination of laxatives over another. General advice is, I'm sure you remember, is a softener plus a stimulant. When you start regular opioids, co-prescribe. Don't wait for them to get bunged up. Don't use PRN, put it on the regular side, or tell them to take it regularly if they're at home. You may have come across naloxegol, which is a specific antidote, really. It's a peripheral mu receptor antagonist. Once a day, 25 milligrams or 12 and a half if they've got renal impairment. And it does not reverse the analgesic effect and may give a nice regular poo, which we all like. I tend to add it in if people are not responding to what we do normally, and I'm too nervous to stop the laxatives. There is some evidence you can do that, but I just take that on a patient by patient basis. So it is difficult because you end up giving them 3 other pills to counteract the side effect of 1 pill. However, talk to them, explain it, and then hopefully it will work. Nausea and vomiting. I like this slide because it helps me in a way sometimes tailor what we do to the patient in terms of cause, but also just gives me a little bit of a visualization of mechanisms and what we're trying to influence. So when you look at all the various neural pathways involved in generating the vomiting reflex and then apply them to the different antiemetics that we're using. The only one here, by the way, that I haven't got is aprepitant, which I'm sure you are all familiar with. It's not yet out in the world in terms of widespread use. However, these are the common ones, as I'm sure you remember. And if you look at the top of the slide, you'll see that the receptors are in different parts of those neural pathways. And if you've got someone with perhaps gastric stasis or squash stomach syndrome from a hepatomegaly, you might want to give them metoclopramide as a prokinetic. If it's more metabolic or drug-induced, cyclizine may be a more effective thing. If you've got no idea and everything's not working, give them levomepromazine as a broad spectrum antiemetic. And then if it's chemotherapy generated sickness, ondansetron's still a very good choice. Down the bottom, olanzapine's coming along. I've not yet really used that in practice, but keep it up your sleeve. Downsides, metoclopramide, extrapyramidal effects. Domperidone's supposed to not do that so much. Haloperidol, again, extrapyramidal, and drowsiness in bigger doses. Cyclizine, I'm sure you know, some people really like if it's given parenterally. I don't worry about that too much. Can make you drowsy, can send elderly patients into delirium. Hyoscine hydrobromide, I tend not to really use as an antiemetic now. It, again, does cause the elderly frail patients quite a lot of trouble with confusion, so I avoid it really. Ondansetron constipation, and then the bottom 2, really drowsiness, sedation, are the big is the big issue with those two drugs. So Rose, she gets on fairly well, ending up on a total of 80 milligrams of morphine over 24 hours, and for the nausea, some cyclizine. So we switched her to long-acting, so MST, 40 BD, and she went along quite nicely for a couple of weeks, and then this is what happened. So quick typing answer. What do you reckon has happened to Rose? Are you with me, Vanita?
Yeah, just waiting. People are typing.
No worries. You're doing very well. I can't see you. You could all have buggered off and made yourselves a cup of tea.
Opioid toxicity.
Yes, very good. And bonus points. What may have happened? What would you do if you saw her in A&E with that story?
People saying dehydrated, sepsis,
Yeah.
renal function, renal failure.
Yeah.
Bill, you've got just under 5 minutes.
Okay, lovely. Nearly there. I think all those things are true. I think lesson for me is if someone develops toxicity on opioids, don't just blame the opioids, look for the reason underneath, because it's highly likely something else has come along, be it an acute kidney injury, hypercalcemia, sepsis. I once had a patient at the Free many years ago, nothing to do with Sarah or Vanita, who had a collapse in the bathroom, having walked there with an HCA and lost consciousness. They put him back to bed and decided it was opioid toxicity. And in fact, he'd had a stroke, and it took them 48 hours to actually realize that. And it just was an example of opioids get blamed for loads of things. You know, if it snows in June, it's because the patient was on opioid. So just always think, why has it happened? Daughters, of course, blamed me for giving her morphine. So these are the clinical features. Pinpoint pupils are right at the bottom in small font because they're totally irrelevant. If you've got drowsiness, confusion, hallucinations, and myoclonic jerks, you're toxic. It's not an overdose. Please don't give naloxone. She had an AKI. Her liver function was also going off. And unfortunately, she just did not respond to fluids. So she went home for end-of-life care. We switched her from morphine to oxynorm, oxycodone, because it's kinder when you have renal impairment. Unfortunately, she continued to be pretty drowsy. And we had a struggle with her daughters, not uncommonly. Quick word on syringe drivers. With Rose, when she went home, we decided we needed to use a syringe driver because she was struggling with oral meds. Alfentanil was our drug of choice in view of her kidney function. It's another opioid, no different really. It's 30 times more potent as a subcut than oral morphine. So she needed a very small dose in terms of milligrams. And this is what we did. In terms of patients going home for end-of-life care, or who you're worried will deteriorate quite quickly and end up being cared for at home for end-of-life care, please always consider the desert island drugs. So these are anticipatory injectable medications, which are handy to have in the house, along with an administration chart, by the way. You can't give them without. So for the district nurses or the palliative care team or a visiting GP, even paramedics can administer these medications if everything is there. So it just really sometimes saves not just an awful lot of hassle in the community, but prevents A&E attendances for people who are dying. Just a quick word on dilemmas. If you don't have dilemmas, clearly you're a psychopath. So if you have dilemmas, it's okay. Be reassured and share them. So these things come up, nutrition, hydration. And I think if I look back at my now 31 years as a doctor, these are becoming more frequent dilemmas. We can do much more, patients and families have all the information at their fingertips about what's available. Google is a blessing and a curse. There's nothing that's hidden in terms of information. Therefore, the conversations become more complex. We have not got the preserve of that information to hide behind, so to speak. So share these dilemmas, be very honest with patients and families, and hopefully you'll never be alone. Sedation is a little bit, what's the word, more down the track in terms of when it becomes a dilemma. Again, share it. It can be extremely difficult, timing wise and also explanation wise. Don't feel like you're on your own. So these are my take home messages. When you are at home, probably sit down, write your ADRT. Please anticipate symptoms for your patients, and don't forget those injectable drugs in anticipation when patients go home in that tenuous condition. And the dilemmas, please share them, and you will have dilemmas for your whole career, and it's okay. And that's my lot.